All right, in this video, we're going to go over a diagnostic sacroiliac joint injection, otherwise known as an SIJ injection. First, let's jump into the fluoroscopic and 3D anatomy. The SIJ is made up of two bones, the ilium, which is part of the innominate, or the hip bone, and the sacrum. The innominate is actually a fusion of the ilium, the pubis, and then the ischium right here. And you can just take a little 3D tour of that. There's the auricular surface right here. You can see those three bones forming right there. We have the lateral aspect of the ilium here, and you can see the iliac crest, iliac tubercle, the anterior superior iliac spine, and the posterior superior iliac spine. You can feel those both on yourself if you push on your hip bone at the very top of it, and more posteriorly behind you. If you push back here, that's that bony prominence right in your lower back. All right, the medial aspect of the ilium. You can see here the auricular structure. It's called so for its ear-like shape. It has either like a C or an L shape. On this ilium, it's actually made up of fibrocartilage versus the sacrum being hyaline cartilage. You can see sort of the shape. So even on this three-dimensional model, I don't think you would normally have these blue spikes coming out, these rods coming out, unless maybe you had a lateral SI fusion. Nonetheless, on this small portion of the ilium, you can see this auricular sort of articular surface on the ilium here too. All right, the other aspect of the SIJ, the sacrum. This is the anterior view or the front view. Some notable features are the promontory right here and the anterior foramen right here, the anterior sacral foramen right here. You can actually even see these on this three-dimensional model right here. And then the promontory, you can see more on a lateral view here too. The lateral aspect of the sacrum, you can see its auricular structure right here, this L-shaped or maybe C-shaped line with hyaline cartilage. And you can see it also on this three-dimensional model. You'll notice that its length is basically around the same length as S1, S2, and S3. And I think what I would take away from looking at this so far is just how strange this joint is, the shape of it. That is good to have in mind when you're looking at fluoroscopic photos, because you're not going to just see a normal hypolucency that would just be some sort of line. It's going to be sort of challenging to see exactly where you are, whether it's this interior portion of the joint or the posterior portion of the joint. We have the posterior aspect of the sacrum. So the sacrum is a fusion of 5 vertebrae. And as we age, these fuse. And typically in our late 20s, these are completely fused. Not everyone's, but most of us. And you can see these bony prominences right here. You can also see them on the three-dimensional model right here. These bony prominences are essentially a continuation of the spinous processes you can feel in your lower back, if you're lumbar, you're thoracic vertebrae. And then you have the lateral sacral crest. So this is the median sacral crest. The lateral sacral crest is the continuation of the transverse processes as they come down from the lumbar spine into the sacrum. Then you have the posterior foramen, which is where the posterior dorsal rami of the spinal nerves branch off to. You can see all those elements right here. So the median sacral crest, lateral sacral crest, the posterior foramen on either side as well. And then just again, look at the strange structure you have on the sort of lateral aspects that articulate with the ilia on both sides. Lastly, you can see this sacral hiatus at the very bottom. So this is the area in which we do a caudal injection, and that's just a side note. And you kind of have landmarks to do that with these sacral cornua. So the sacroiliac joint is really important as it basically transmits forces from our upper body, so up here, to our lower body through our hips into our legs, so through the femurs right here. And you can see just how everything is so interconnected. It's so special that it has its own name for the way in which it moves. It's called nutation and counternutation, I think in reference, or that means essentially nodding. So you can see how you can almost see the sacrum nodding forward. So this anterior-inferior movement of the sacral promontory, and then this posterior movement of the coccyx. Counternutation is essentially the exact opposite of that. So this posterior movement with the anterior movement of the coccyx right there. This affects the shape of the ilia as they move back and forth, and even the shape of the symphysis pubis right here too. At any rate, I'm not going to get too stuck on the biomechanics of the sacroiliac joint. That really requires a very, very good PT or kinesiologist or a chiropractor. So this is about a SIJ injection, and so we'll go ahead and just move forward. I think there's around 2 to 4 degrees of this nutation, counter-nutation, but I think we'll just move on from now. Jump into the ligaments of the SIJ. We're not going to talk about all the ligaments of the hips. There are a lot, but starting off, we'll have the anterior sacroiliac ligament. It essentially comes from around like the third segment of the sacrum, laterally, both sides to end in front of the joint or around the auricular surface of the ilia. Then posteriorly, we have the posterior sacroiliac ligament, which is composed of 2 ligaments, the short and the long. The short is from the first and second transverse tubercles of the sacrum, and it attaches to the tuberosity of the ilia. And then you have the long sacroiliac ligament, which comes from the third and fourth transverse tubercles of the sacrum, stretching to the PSIS, so the posterior superior iliac spine. The sacrotuberous ligament. So you have the ischial tuberosity right here, attaching to the sacrum from around the fourth, fifth transverse tubercles of the sacrum, and also part of the coccyx right here too. The ischial spine attaching to the sacrum, aptly named sacrospinous ligament. It attaches from this lower aspect of the sacrum and the superior aspect of the coccyx down to the ischial spine right here. And it's worth noting these 2 sacrotuberous and sacrospinous ligaments essentially make up our greater sciatic and lesser sciatic foramen. Not that this talks about a caudal injection, but I thought it'd be worth mentioning the posterior, superficial, and deep sacrococcygeal ligaments just because they're involved with caudal injections, and we're in this space already. This is just a 3D model on your screen of the sacrum, of everything we just spoke about, and really not too much more to discuss here except for these superior articular facets. Also, I pay for this subscription in the anatomy app, and if I'm paying for it, I may as well be showing it to you. So here's the auricular surface, the sacrotuberosity. Just again, how sort of strange this joint is. Again, you can sort of see the angle by which it is articulating with the ilium or ilia on both sides too. Something else worth mentioning would be the innervation of the SI joint. Depending on where you read or who you talk to, you might see different things for the innervation of the joint or the ligamentous structures, like the dorsal rami of S1, S2, sort of the spinal nerves coming through this sacral canal and then coming out these posterior foramen innervating the joint, the ventral rami of L4, L5, the superior gluteal nerve or the obturator nerve. So I won't dig too much into the weeds on that, and we can go ahead and get started talking about the equipment you'll need and get started with the procedure. All right, these are some of the things you'll need. First of all, you'll need a Mayo stand, and then a sterile drape, surgical scrub prep, a 18 1.5-inch hypodermic needle for drawing up medication. That's also useful for indicating where you intend to inject on the patient. A 5cc syringe for skin infiltration with a 1.5-inch 25-gauge hypodermic needle for skin infiltration. A 3cc syringe for contrast. A 25 or 22-gauge 3.5-inch spinal needle or Quincke needle. And a 3cc syringe for your inject date. Last but not least, sterile gloves. Our patient's in the prone position, so we can go ahead and get started. So I'll caveat this video by saying there are many ways to do an SI joint injection. This is just one of them. In this video, we will be aiming to make the inferior 1/3 or the caudalmost 1/3 of the joint as maximally crisp and radiolucent as possible. So we'll go ahead and take an AP image now. this is kind of even why I made these videos to begin with, is because fluoroscopic SI joint anatomy is sort of challenging and there's a lot to go over. So for instance, like this is the sacral ala, the sacral body, sacral wing, and this is almost an AP projection image of our SI joint. However, look at these spinous processes of the sacrum. These are sort of, there's a shadowing over here, so they're not exactly midline. And then some more anatomy here. So what is this? You've got this little circle. Maybe you would even go as far as calling it a P shape. And then you have this right here. Maybe you would even go as far as calling it an almond shape. So these are sacral foramen, and this P and A sort of distinction can help you decide whether or not you're looking at a posterior sacral foramen or an anterior sacral foramen. And speaking of posterior anterior, so you have this, I like to think of them as rivers almost. River here, and then this river here. And how do you know which is anterior, which is posterior? So these are the anterior and posterior margins of the SI joint. Typically, this lateral one is going to be the anterior, and then typically this more medial one is going to be your posterior. So exactly where you're aiming, right here. And then we have some more almond shapes here of our sacral foramen. You can see this pretty well on the 3D model too. So you can see the sacral foramen here. This would be the posterior ones, and you have the anterior ones. You can see your SI joint and how the SI joint is kind of around a 30-degree angle posteriorly. So that's why, you know, when you're looking at an AP image, you're not going to see just hypolucency like slit down the middle. It's at an angle in the first place. And then you can see your sacral ala here, these sacral bodies. We have our AP image now, and I just want to add that prior to doing so, make sure to clean the patient, and I try to have some towels over the behind of the patient. This is a rather exposed procedure. Make sure you warn patients ahead of the procedure that how much of their pants will be pulled down so that you give them that heads up, and then you'll have a sterile field. So now we will optimize that inferior 1/3 of that caudal 1/3 of the joint. All right, let's bring it all together and do it live. Let's do it live! For objects that are superimposed when you're taking fluoroscopic photos, like the anterior and posterior joint margins of the SI joint can be, the most superficial, or the image or object closest to the image intensifier, so the top of the C-arm, will move in the opposite direction as you are obliquing. So in this case, the posterior margin of the SI joint should be moving to the right while we oblique the C-arm to the left. Let's look at that one more time for the folks in the back. We chose about a 10 to 15 degrees contralateral oblique to make this as maximally crisp as possible. And we will target one. Oh my gosh, that's a bad one. Oh, that's terrible. Centimeter above the most inferior aspect of the joint. So up here. And normally we wouldn't be doing live fluoroscopy to find this. Typically, you just need to take 1 or 2 fluoroscopic photos to find out this maximally hypolucent area too. But that was just for demonstration purposes. We've made the inferior 1/3 of the joint pretty crisp. So now we'll aim for 1 to 2 centimeters above that area and then infiltrate the skin with some local anesthetic. So I'll put down my marker and then take an image to see where I am. You can now see the tip of the 1.5 25 gauge hypodermic needle laying over the inferior aspect of the sacroiliac joint. Great, that looks good. So we'll go ahead and infiltrate the skin with some local anesthetic and proceed with the injection. So the skin's numb, so next we'll proceed with a 22 gauge 3.5 inch spinal needle or Quincke needle. And we've left the local skin infiltrate needle in just to mark our area. Next, we'll advance until we hit the joint space, or if we hit os, we'll reposition our needle and attempt to enter into the joint. So now we have a coaxial or barrel view of our needle going into the joint. Ideally, you should sort of bias medially such that you can slip into the posterior aspect of the SI joint. So I've just hit that gummy consistency or that rubbery consistency, which is the posterior ligament of the sacroiliac joint. At this point, we'll check the depth of our injection. We have a lateral view of the SI joint now. This can be a little bit confusing because it is a very irregular shape, but you see our needle here, and it is entering in probably out right here where the joint, or at least the synovial or the articular aspect of the joint would be. So remember, it's irregular shape, which, is in reference to its ear-like, L-like shape. So it would probably look something like this if we were to inject contrast. We rotated the C-arm for a lateral image to check the depth of our needle and to make sure that we're in the joint. At this point, we'll inject some contrast, check a lateral view, and then a contralateral or an AP view as well. Okay, we've taken another contralateral oblique view and another lateral view after having injected contrast. I don't actually have contrast, and you can't inject contrast into this mannequin or model, but the main thing is you're looking for spread within the joint lines and not extravasation, so contrast spread outside of the joint lines. In order to really evaluate contrast spread, you actually need photos of it, so I'll skip that point for now, and then hopefully in some point in the future, I can have photos that would, show optimal contrast spread in the SI joint and other injections, for instance. Okay, we've injected contrast, we've checked multiple views, we don't see an extravasation, and we're happy with our contrast spread. At this point, we can go ahead and inject our injectate. So that's not going to be more than usually 2 to 2.5 cc's of injectate. And just to give you another view here, we have our needle going to the SI joint. And we peel back the skin, not real skin, and then actually look at where this needle is going, you can see multiple trajectories already taking place right into the SI joint right here. One last thing is that some practitioners use a little bit of cephalad, so towards the head tilt of the II, the image intensifier. So now the C-arm is actually tilted towards us, towards the head, and we'll take a look at what that looks like on the fluoro images. With the cephalad tilt, the posterior margin of the sacroiliac joint becomes a little bit longer, it lengthens the posterior element. So some practitioners prefer this because it can make it a little bit easier to see. Anyways, bye!